This video, I'll be going over 7 most common neurotransmitters in psychiatry. I'll also talk about the association with different psychiatric disorders. It is very important to know that it is very high yield in the test. Knowing the neurotransmitters, knowing their implication anytime they have an imbalance is very important for the test. What am I expecting every student to know? I'm expecting us to know the area of production where those neurotransmitters are being synthesized. I want every student to know about the functions of the neurotransmitters and also the implications of the imbalance, either in the high level or in the low level. When it is high, when it is low, what is the implication in psychiatry? So with the 7 neurotransmitters, I'll be using the acronym of GAS-END. As you always know, that it's always better for students to learn in a very easy way. So let's use the acronym of GAS-END, G-A-S-E-N-D. But have it in mind that the G is G raised to power 2, 2-letter G, and the N that we have here, we have 2 N. GAS-END, G-A-S-E-N-D. So the first G is GABA, the second G is glutamate, then the A is the acetylcholine, the S is serotonin, the E is epinephrine, the N is norepinephrine, the second N is the neuropeptides, and the D is dopamine. So using the acronym of GAS-END, let's use it that way. I'll repeat again. We have the GABA, which is our G1, the G2 is glutamate, the A is acetylcholine, the S is serotonin, the E is epinephrine, then the N is norepinephrine, the second N is neuropeptide, and lastly we have the dopamine. So that gives us the acronym of GAS-END. So to start with, I'm going to start with the first one, which is GABA. GABA is the acronym, or in a simple way. So let's make it more extended. That is gamma aminobutyric acid. This is the most abundant inhibitory neurotransmitter. It is more of a relaxing neurotransmitter. It's a calming neurotransmitter. When you have GABA in your system, there is possibility of more relaxation. So it calms the central nervous system. It also helps to increase our focus when we have enough GABA in the system. So when there is a decreased GABA, there is possibility of the patient having a high level of anxiety. The patient is going to be on the high side because there is a low GABA. So basically, it is also important to know that it is the site of action for most of these sedatives. All the central nervous system works on the GABA receptors. And what are the examples of the sedatives? The benzodiazepines, alcohol, and the barbiturates. So when you give a patient any kind of these benzodiazepines or these sedative, is going to bind with GABA receptors, and that is going to potentiate more calming effects as a result of the GABA. So when a patient is having anxiety, so we can say basically that they have a low GABA or any low GABA derivative. So when we give sedative to the patient or the benzos, an example is Activan. So invariably, we are possibly giving patient the GABA derivatives. So in that situation, that will help to lower the anxiety level of the patient. Don't forget that when they have a low GABA, that means the patient has what? More of the anxiety. So you're going to give them something that look like a GABA. So like a GABA derivative in form of the benzos, the Activan, and that will lower the anxiety of the patient. So basically, that is all we need to know in the aspect of what? GABA and its connection with the test-related information. So let's go to the second one, which is the glutamate, which is the second G. This is the excitatory neurotransmitter. So we can just say that it's like the opposite of GABA. GABA is more of inhibitory, while glutamate is the excitatory. And how do you differentiate? The last letter word in the glutamate is the E. So you can use E and E phenomenon to identify glutamate. Glutamate is ending with the word E. So we can use that to say E and E is going to be excitatory. So since we said GABA and glutamate is going to do opposite. So if glutamate is excitatory, so that shows that GABA will be inhibitory. So what that does, the word excitatory is just an English expression. It makes the patient to be all over everywhere. Patient is going to be more activated. They are going to be more excited. And I've just said it's just the opposite of GABA, because GABA is kind of relaxing. It's a calming neurotransmitter, while glutamate is an exciting neurotransmitter. It's going to activate the patient more and make them to be more excited. So when we have increased level of glutamate, so most of the time this is implicated in seizure disorders, in all the bipolar disorders, all these psychosis, because there's excessive production of glutamate in those situations. I'll repeat again, in a situation where we have seizure We have bipolar disorder, psychosis. That shows that there is excitatory level. The patient has more of the glutamate in their system. So it's also kind of implicated in most mood disorder as well as schizophrenia. But in a situation where we have a low glutamate, you will see a low glutamate in situation related to memory and learning difficulty, or when a patient is having a negative symptoms of schizophrenia. In negative symptoms of schizophrenia, they are having hydonia, avolition, as well as affect incongruity. So you might see a low glutamate in a negative symptoms of schizophrenia, or patient that is having a memory or learning difficulties. The third one will be our acetylcholine. Don't forget we are using the acronym of gas end. So we have done the G1, the G2. The next one is the acetylcholine. So the word acetylcholine is coming from the cholinergic standpoint. The choline basically helps with memory. Where is this produced? I've said from the introduction, I'm expecting you to know where they are being produced from. So the one that is very high yield in the exam, we are going to be talking about the site of production, which is where they are being synthesized. We want to talk about their function. We also want to talk about the abnormality, anytime it is high or low. So the site of production, we begin to talk about that from now on. So for the acetylcholine, it is produced in the basal nucleus of Meninite. Acetylcholine, we just say the BSM, acetylcholine, basal nucleus of Meninite. So basically the acetylcholine is needed for learning. All our short-term memory is needed for arousal. It's also implicated in our reward system. You want to keep something in mind that acetylcholine is implicated in the word Alzheimer's disease. So how do we want to bring this in? When we have a low level of acetylcholine, patient is likely going to have Alzheimer's disease or all this impairment in memory. And how do you remember this? Alzheimer's disease, we have A and L, which is the first letter word and the second letter word. The A is the first one and the L is the second word in Alzheimer's. So you just blow out those two words and say that in Alzheimer's disease, there is a low level of acetylcholine. You take the L in Alzheimer's disease and say a low. Then you take the A that is starting in Alzheimer's disease and say in Alzheimer's disease, we have A and L as the two-letter words that is starting the word Alzheimer's disease. I will just say there's a low acetylcholine in Alzheimer's disease. And I've just introduced, I said Alzheimer's disease is the opposite of Parkinson. So since we have a low level of acetylcholine in Alzheimer's disease, so basically we are going to have high level of acetylcholine in Parkinson's disease. Very important for the exam. So low level of acetylcholine is going to be seen in patient who has Alzheimer's disease or any impairment of memory. And it is important to know that in Alzheimer's disease, there is a decreased acetylcholine, there is an increased dopamine, and there is a decreased glutamate. I'll repeat that again. In Alzheimer's disease, because this is very high yield in the exam, a decreased acetylcholine, and when the acetylcholine is decreased, we know that acetylcholine and dopamine does reciprocity. I've done that in one of our videos. So when the acetylcholine is low in Alzheimer's disease, the dopamine is going to be high. Sometimes they ask in the exam the implication of glutamate in respect to Alzheimer's disease. So the glutamate is also low. So we have a decreased acetylcholine, increased dopamine, and a decreased glutamate in Alzheimer's disease. So since we said it's an opposite of Parkinson, let's further emphasize that in Parkinson's disease, there's going to be increased acetylcholine because it does the opposite, and a decreased dopamine. And that explains that. So that takes us to the fourth neurotransmitter, which is our serotonin. Serotonin is otherwise known as indole, I-N-D-O-L-E. The precursor of serotonin is tryptophan. Very important to know that before serotonin can be produced, we have a precursor, where it's coming from, and that is our tryptophan. Another name for serotonin is 5-hydroxytryptamine, 5-HT. So most of the time you see in most of the tests, 5-HT, we are talking about serotonin. What are the functions of serotonin? Basically, it is needed for the mood, for sleep, and for GI regulation. Even if you don't remember anything, just use the word MSG. M, S, and G for mood, for sleep, and GI regulation. That is enough for you. But if you still want to know more of the function of serotonin, it is needed for satiety, for temperature, and it's also for pain regulation. We need to know where it is being produced from because it's very high yield in the exam. Serotonin is produced in the raphe nuclei of the brainstem. So it is also implicated in all this mood and anxiety disorder. So let's start with the imbalance. I've said we are going to know the function of those neurotransmitters. We want to know where they are being produced from, and you also want to know their implication anytime there's an imbalance. That is the only 3 things they are going to ask in the exam, so you can go straight to the point. So when we have an imbalance of serotonin, a low serotonin, you will see that in patient that has depression, or the people that have OCD, anxiety-related disorder, anything related to personality disorders. You will see that when they have a low serotonin, you will see it in depression, in OCD, in anxiety disorder sometimes, in personality disorders, and that is that. So let's go to the 5th neurotransmitter, which is our norepinephrine. It is important to know that norepinephrine is otherwise known as noradrenaline. These 2 words can be used interchangeably. A particular test writer can use the word norepinephrine, another person can use the word noradrenaline. It's the same. Then we go further. The word epinephrine is referred to as what? Adrenaline. We use epinephrine and adrenaline together. Don't forget that, please. Epinephrine can be changed to adrenaline, while norepinephrine can be changed to noradrenaline. So let's go further. For norepinephrine, in the exam, this is also very high yield. It is produced in the locus coeruleus of the pons. In the locus coeruleus, that is very important for norepinephrine. And the precursor for norepinephrine is thyroxine. Thyroxine is the precursor for norepinephrine. So what are the functions of this norepinephrine? Basically, it is implicated in mood, arousal, reward, attention, anxiety, and any form of this concentration disorder. So let's quickly dive into epinephrine. Epinephrine is one of the catecholamines. So the word catecholamine is kind of an umbrella word. Some textbook or some test writers will see catecholamine as combination of dopamine, epinephrine, and norepinephrine. Some categorize it as just the dopamine as well as the epinephrine. We just say epinephrine is also part of the catecholamine. So epinephrine is produced in the adrenal glands, and it is known to be the FFF hormone. What do I mean by FFF hormone? The fear, the fight, and the flight hormone. That anytime we are going through an anxiety-based situation, there's going to be epinephrine production, which will make the person to be afraid, and the person will want to make a decision. Do I need to fight or do I need to run away, which is the flight aspect of it. So an increased level of norepinephrine is going to be seen in patient that has an anxiety. You are going to see them all over the place. So the 6th one is the neuropeptide. This is not most commonly asked in the exam, but 1 or 2 students can get questions related to that. The examples of that are the substance P, the endorphins. So basically they are produced anytime an individual is having a stress-related problem or they have any kind of injury. It is also involved in pain perception most often. So the 7th neurotransmitter is the dopamine. So we need to know the basic function of dopamine. It's needed for our pleasure reward, for addiction, for movement, and for motivation. Where is dopamine produced from? Very high yield in the exam. It is produced in the VTA, the ventral tegmental area in the midbrain. Basically, we have a major videos about the dopamine pathway. So when we have high level of dopamine, we are going to see it being increased in schizophrenia, in psychosis and mania. And when we have a low level of dopamine, we can see that in patients that have substance abuse disorder, those that are presenting with anhedonia, and those that has Parkinson's disease. I'll repeat again. Increased level of dopamine should be seen in schizophrenia, psychosis, and mania. And low level of dopamine will be seen in substance abuse disorder, anhedonia, and Parkinson's disease. It is very important for us to know how dopamine comes by in the aspect of the pathways. Basically, there's no one going for the PMHNP exam that will not know all the 4 pathways of dopamine because it's very high yield in the exam. Dopamine has 4 pathways. I've made a very major video on different types of this pathway. Just for revision purpose, I'll just dive into that a little bit briefly. So we use the acronym of MMTN to explain the 4 pathways of dopamine, M, M, T, and N. Or you can say MTN, but have it in mind that the M is M raised to power 2. The mesolimbic pathway the mesocortical pathway, the tuberoinfundibular pathway, and the nigrostriatal pathway. Those are the 4 pathways. So let's just dive into that briefly. The first pathway is the mesolimbic pathway. Dopamine basically is going to travel from the VTA to the NA. There is high level of dopamine in a patient that has schizophrenia or psychosis in context to this pathway that I've just established. And that's why you see patient having a lot of positive symptoms. That is the delusion, the hallucination, the bizarre behaviors. Those are the positive symptoms you will see in the patient. Delusion, hallucination, bizarre behaviors, and that is basically the positive symptoms. So in this case, there is high level of dopamine in this mesolimbic pathway, and that's the reason for all these psychotic features that we have explained. When the patient is given antipsychotic medication, the aim of this antipsychotic medication is to lower the dopamine in that pathway. So when it lowers the dopamine, the patient positive symptoms is also going to decrease. So you will see them having a kind of reduction in the hallucination, delusion. It might even fade away because of the use of antipsychotic. The antipsychotic will lower the dopamine in this pathway. Don't forget that initially there was excessive production of dopamine in the mesolimbic pathway. So that takes us to the mesocortical pathway, which is the second pathway. So this pathway is also needed in context of this psychosis and schizophrenia. So what dopamine does here, the dopamine is going to be moving, is going to be traveling from the VTA to the cortex. But in this pathway, there is actually, patient is presenting with what? A negative symptoms. And what is bringing the negative symptoms? In psychosis or schizophrenia, there is a low level of dopamine production in the mesocortical pathway. And that is this one, student has to be very careful about these 2 pathways. In the mesolimbic pathway, there is excess dopamine production. But in the mesocortical pathway, there is a low dopamine production in context of schizophrenia. So when we give antipsychotic medication to the patient, by the time it gets to this pathway, which is this mesocortical pathway, the aim of antipsychotic is to lower the dopamine. So when it gets to the mesocortical pathway, especially the first generation antipsychotic, the FGA. So this first generation antipsychotic that we call the typical antipsychotic is going to lower dopamine further in the mesocortical pathway, and that is the reason why we see more of these negative symptoms. It's going to worsen the negative symptoms further. In the mesocortical pathway, going by the pathophysiology of schizophrenia, there was actually a low dopamine. Now, giving antipsychotic to the patient is going to further lower the dopamine in that pathway, the mesocortical pathway, and that will worsen the negative symptoms further. And that's why you see the patient having more sustainers. They are going to sustain what they have before: the apathy, the ambivalence, the affect incongruity, all the 5 A's that we have established in our previous video. Patient will still maintain those 5 A's because the medication is further lowering the dopamine in the mesocortical pathway, and that will lower that will make them to have more of the negative symptoms, even though the medication will reduce the positive symptoms, because in the mesolimbic pathway it will reduce the dopamine, and that will reduce the positive symptoms. This is basically connected to the first generation antipsychotic. And why is this coming by? The drug is lacking sensitivity to different brain areas, and that is causing this unwanted side effect that I've just explained. We really see this with the atypical antipsychotic. With the atypical antipsychotic, they always have a better reaction to the negative symptoms, because with the atypical, that will increase the dopamine in the mesocortical pathway, and that is why you don't see them having the negative symptoms when they are taking the new generation antipsychotic, which is the second generation antipsychotic. So we go further to the third pathway, the nigrostriatal pathway. This pathway is known for motor coordination. And what is going on with the dopamine here? There is high level of dopamine, and it's traveling from the substantia nigra to the corpus striatum. It's traveling from the substantia nigra to the striatum, and that place is needed for motor coordination. So when we give antipsychotic to schizophrenic patient, what this does is to lower the dopamine in this pathway. So when it lowers the dopamine in this pathway, basically is going to make acetylcholine production to be more. Dopamine and acetylcholine are always doing reciprocity. When we lower dopamine in the neurotransmitter pathway, automatically there will be what? More production of acetylcholine, and that's why you see the patient presenting with what? Pseudo Parkinsonism. So how does that come by? There's going to be a low dopamine and high acetylcholine, and that will lead to these uncoordinated movements which we see in the extrapyramidal side effect. Most of the time we just say patient has a pseudo Parkinsonism. We have made a major video on this. Go to our YouTube channel. You will see more. You will learn more about all these extrapyramidal side effects. I made it in a very brief way for every student to understand that. And the last one is the fourth dopamine pathway, which is the tuberoinfundibular pathway. So what happens here is that there's excessive dopamine production, and it's traveled from the hypothalamus to the pituitary gland. So when we give antipsychotic to the patient, what antipsychotic does is to lower the dopamine in this pathway. As it's lowering the dopamine, there's going to be increased production of prolactin. Dopamine and prolactin also do reciprocity. When dopamine is low, prolactin is going to be high. So once there is high level of prolactin as a result of this tuberoinfundibular pathway, our aim is to lower the dopamine with our antipsychotic medication, and that will increase what? The prolactin production. So there's going to be what? Galactoria, excessive milk production, and you will see patients complaining of milk production from their breast, and that is as a result of what? High level of prolactin, since we are blocking the dopamine. So basically, there is increased dopamine in the mesolimbic pathway. There is a decreased dopamine in the mesocortical pathway. Those two, we are going to be emphasizing that we need to know the difference between this increase and decreased dopamine in these two pathways. There is high level of dopamine in the mesolimbic pathway, but there is a low level of dopamine in the mesocortical pathway. Know how it's coming by, and know how the medication is going to be interplaying in these two pathways. So finally, for test-taking strategy, we need to synopsize the imbalance of these neurotransmitters. One thing is to know the type of neurotransmitter, the function of the neurotransmitter, where those neurotransmitters are being produced. Another thing is to know when we have an imbalance. Don't forget that the word imbalance means either high or low. So when we say we have an impairment or we have an imbalance, it can be either high or low. So when we have imbalance of this neurotransmitter, what is going to come by? So in patient that has antisocial personality disorder, that means they have a decreased dopamine. Please, let's be precise about it. A decreased dopamine, they will have antisocial personality disorder. In bipolar disorder, patient is having increased dopamine, a high level of norepinephrine, high level of glutamate, and a low serotonin. I'll repeat that again. In bipolar disorder, increased dopamine, high norepinephrine, high glutamate, and a low serotonin. Let's go to anxiety disorder. In anxiety disorder, patient has a decreased GABA. They have increased norepinephrine, and they have a decreased serotonin. Anxiety disorder, a decrease in GABA, an increase in norepinephrine, and a decrease in serotonin. Substance abuse disorder, patient will be having a decreased opioid neuropeptides. One of our gas end, our end there that we have there, is the neuropeptide. So you see them having a decreased opioid neuropeptide and a decreased dopamine. That is substance abuse disorder. In psychosis, which is the big major one, and schizophrenia, patient is having high level of glutamate and high level of dopamine. This is very high yield, high glutamate, high dopamine in psychosis and schizophrenia. In autism, patient will have impairment of their glutamate, serotonin, as well as what? GABA, an imbalance in glutamate, serotonin, and GABA. I'm very precise to use the word imbalance. Imbalance in glutamate, serotonin, and GABA. In addiction disorder, all the forms of addiction, patient has an impairment of their GABA as well as dopamine. In OCD, patient will have a decreased serotonin and norepinephrine. In OCD, obsessive compulsive disorder, a decrease in serotonin and norepinephrine. In Tourette disorder, Tourette disorder, they will have an impairment in serotonin, in GABA, in glutamate, and norepinephrine. Tourette disorder, an impairment in serotonin, GABA, glutamate, and norepinephrine. In mood disorder, basically patient has an impairment in serotonin as well as what? Norepinephrine. In ADHD, there is a problem with what dopamine, serotonin, and norepinephrine, and impairment in dopamine, serotonin, and norepinephrine, that is ADHD. So, and that recaps everything. So for us to have, if you want to have more detailed content review, this is just a synopsis, an introduction to different types of neurotransmitter, where they are being produced, and when they have any kind of imbalance, what are the implications. So for more detailed content review, kindly visit our website for registration at www.advancednpcertificationreviews.com, or you can call my direct number, Dr. Kemi Akinlawon, at 281-372-9148, or also you can send me a WhatsApp message at the same number, 281-372-9148. Thank you for your rapt attention.